include the exit sound. So this is something that we've started with, mainly ENT department, neonatologists, obstetricians. We set up a team about 3 years ago, maybe 2 years ago. Exit means ex utero intrapartum treatment. And it's basically a bunch of disorders where the kids or the fetus has a life-threatening condition which may need to be either excised prior to delivery, so the placenta acts as the oxygenating, the bypass oxygenating unit, and or it's got a threatened airway which may or may not be intubatable, and if it's not intubatable, it may or may not be able to do a trachea. So essentially it evolves, it's a bit of a circus. There are about 20 people that come together, and you need to coordinate and work through the... Where are we going now?
The next keyboard up.
Oh, there we go. Okay.
Just press arrow on the keyboard. No, this one here.
That one.
Yeah, this one doesn't do anything. It's just
okay. It's laptop. So, just as way of introduction, I'm just going to go through a few things. The history, a little bit of history, the indications for exit. And the reason why it's been chosen as a topic by Agnes is simply because it involves a lot of people, and because there are a lot of different specialities here today, she thought it was a good idea. So we'll go through the indications, the planning, and how we set up things, and discuss a little bit on the maternal concerns, and obviously the fetal neonatal transition. The maternal concerns is that there's no benefit to the mother, except that she may or may not have a delivery of a live baby. I'll get it right eventually. Okay, so it all starts when the obstetrician and or fetal specialist sees this sort of thing in antenatal clinic. They do an ultrasound, they see something which is unusual, they get in the specialist, and in this case the kiddie's got a cystic hygroma. There's a debate as to whether it is better to do an ultrasound or better to do an MRI, and which one gives you more information. Obviously there's some units that don't always have MRIs, but the ultrasound is good enough to send these kids through. Now the problem is that the diagnosis is simply in 2D at the moment. There is 3D available, and you're seeing images which look like a lousy television set from the 1930s, because it's black and white, and yes, you can bring in Doppler and bring in a bit of color, but you can't always tell exactly what's going on, and whether this is actually a threatened airway, or whether this is intubatable, or whether anything can actually be done. And that's the big debate as to whether the exit procedure should take place. And so, there's just another image. This was a video, but I couldn't get it to work last night. So once you've made the prenatal evaluation, you've got your imaging, this is a sort of algorithm that you have to work through. Obviously the posterior neck masses with no airway compression, no big deal. Let them deliver, usually by cesarean section if the mass is big enough. If you've got an anterior neck mass or laryngeal or trachea anomaly, and there's airway compression or absence of airway or indefinable airway, that leads onto the next step, where you have prenatal counseling and you plan the exit procedure. Because you've got to decide whether this is, one, a viable fetus, two, what the chromosomal defect is, discuss with the family whether they actually want to go on to a delivery, and in some cases we've had that situation when the parents don't want anything done. But it all takes a planning, discussion. Some of the causes of potential causes for or indications for an exit procedure may lead to polyhydramnios, which may precipitate preterm labor. And then you've got the double risk of the difficult airway or difficult problem and prematurity. And we've been in, or an emergency procedure, which could then, doing things in the middle of the night and the weekend when not everybody is available certainly adds to the challenge. So once you get to the exit procedure, you then got to decide whether you're going to go with direct laryngoscopy and intubate, with or without ultrasound guidance, and we'll get onto that. Whether you're going to need fiber optic or whether you're going to need a rigid bronchoscopy. And to do this in a situation where the baby is essentially lying between mother's legs on the table, being delivered with cesarean section, the head and shoulders are the only thing that are usually delivered, and that's the only thing that's accessible, is not the easiest situation to be in. And on top of that, you don't have the same visual clues that you have in OR and ICU. You don't have air coming in and out of the airway, because the aim of the obstetric anesthesiologist is to make sure that this kid doesn't breathe. Because once it starts breathing, that sets up a chain of events which can precipitate delivery of the placenta. And that's what you don't want, because if you don't have a placenta, you don't have oxygenation, and you've got the baby then is at risk. So that's kind of what you have to work through. These are some of the indications that are listed in many of the articles on exit. And basically it boils down into the airway procedure where there's a potential problem. Tracheal atresia, laryngeal atresia is a special problem on its own, which Andy can go into later. Exit to resection. So there are situations where you may want to excise whatever is causing the problem, or it can go on to, like a pericardial teratoma. These are heroic procedures that have been done with the baby still attached to the placenta. If it's a severe congenital diaphragmatic hernia or congenital heart disease, you may go from exit, and while the kid is attached to the placenta, you go straight onto ECMO, deliver, and then do whatever cardiac procedure, because you've now got the ECMO acting as your oxygenator. And then very occasionally conjoined twins. 75% of conjoined twins don't make it to live birth, and so if you find conjoined twins, you may want to do something which will improve their chances of survival. So many of these, as I say, historically, exit was first used for CDH, where they would put a plug into the trachea, because some very clever lateral thinker in the past noted that a kiddie with laryngeal atresia had normal development of his lungs. And he put two and two together and said, okay, maybe with CDH, if we plugged the trachea, then his lungs would develop normally. And it turned out it did in the animal model, and they've subsequently done it not always successfully, but they've done it with CDH. And so the initial procedure is to plug it at about 28 weeks and then remove the plug at about 34 weeks, and the lungs have developed, and the CDH does a lot better. So that's the historical background. But obviously once you've got a technique and a procedure, then people take it further and develop it further and try to salvage what would probably be, certainly in the developing world, would be a death at birth, because we just simply don't have the facilities or the personnel to do these things. Having said that, I got an email from a colleague in Bloemfontein, South Africa, which is in the middle of Afrikanerdom, and they did their first one last week. So even the developing world can develop. So you can see in this situation, here's a kiddie that's been delivered, still attached, and he's got a massive tumor which is going to prevent intubation. Excising this tumor is going to be a bit tricky because it's a little bit bloody, and so you need to get IV access before you even start. So this adds to all the problems that you have to face in this situation, where you're not simply trying to establish an airway. You've got to get all your ducks in a row here, otherwise there's going to be a lot of action in that operating room. So as far as the mother's concerned, this is taken from a radiographics journal and a teaching point, which I thought was kind of summed it up, and it made it very easy to cut and paste this morning when I added it to my talk. So the bottom line is you don't want placental detachment, otherwise you lose your oxygenation. But you don't want to drop the mother's blood pressure. But everything you use to relax the uterus will drop the mother's blood pressure. The tocolytics will drop it. So you've got uppers and downers going. You've got the things to vasoconstrict and things to relax and vasodilate. But it's putting the mother at risk because she's going to be hypotensive. She's going to have deep anesthesia. She's going to have potentially prolonged anesthesia. They've managed a 2.5-hour exit procedure and forget where it was, but it can go for that long. The longest we've done, that I've been involved with anyway, I've been involved with 5, although we've done about 8 exit procedures. The other 3 were basically the kids started breathing, so it wasn't really necessary. But the latest one, who's still in the unit and very infected at the moment, but he had a 64-minute. And then all of a sudden the placenta decided it wanted to come out. So we then had to crash off and try and intubate in the room next door. So it's important from the mother's point of view, and it's important that we care for the mother, because obviously if there are a lot of things that we do that are going to cause hypertension, a lot of things that are going to vasodilate, which runs the risk of hemorrhage. So you've got uppers and downers. So from the obstetric side of things, or the obstetric anesthesiologist sides of things, you've got those are the risks which I mentioned. General anesthesia versus epidural. Now some suggest that epidural would be better for the baby. I don't believe that. It might be better for the baby in that it will, we know that an epidural improves baby's outcome in a normal situation. But you don't want a kitty to be wide awake and wanting to breathe. You want to have him stunned completely, apneic during the procedure, so that you can basically anesthetize as well. So an epidural won't do that. I've just recently reviewed an article where they talked about epidural and remifentanil. Remifentanil gets through the placenta, although I doubt that it's going to last very long once it's through the placenta. However, they suggested that this was the technique that they were using down in Duke, and that it was an ideal technique. That's debatable. Versus GA, where you can anesthetize the baby through the placenta and keep him quiet, keep him still, or keep her still. The tocolytics, as I mentioned, inhalation anesthesia plus nitroglycerine equals hypertension, but the tocolytics are what we're going to use to paralyze the uterus or to relax the uterus. And then your uppers and downers, it depends which year that you're doing obstetrics, whether ephedrine's the best one or phenylephrine the best one. You take your pick as long as you get the blood pressure up. And obviously you need to have adequate fluid balance. So that's got nothing to do with difficult airways or an airway workshop. The next step is the baby that we need to deliver. And this is the minimum amount of personnel that you require in this. And this is kind of how we've developed. The UW has followed this model. And you can see there's a lot of stuff happening. Mother in the middle in white. You've got the surgeon, obstetrician, and the surgical tech. That's the obstetric side, and this is now the pediatric side, or the fetus side, where you've got another the assistant surgeon, pediatric otolaryngologist, ENT surgeon, anesthesiologist, which occasionally has been me, ultrasound people because we need to monitor the baby. We need to check to see whether we've actually intubated the airway if we can. And then the anaesthetist back there, sonographer, radiologist to decipher what we're actually looking at. And then the team in the background waiting for action. They like the vultures because are they going to be able to intubate or not? The neonatologists sometimes feel that they've got a better chance of intubating. The pediatric anesthesiologist definitely thinks he can intubate better than the ENT surgeon, depending on who's there and what instruments he uses. I say that simply because the ones that I've been involved with, we've lost the airway either in transit, you've battled, you've got your bronchoscope, you intubated, and then you move them next door and somebody pulls the tube out, or they haven't been able to intubate and the kid starts breathing. So bottom line is you need somebody who is skilled at the airway and airway management and intubating in this environment. I'm just having a little dig, Andy, it's okay. Don't take it personally. So it's what happens is the obstetrician makes the phalansteal incision. Then as soon as they open the relaxed uterus, you've got to have a controlled release of the liquor. Otherwise, you're going to have a sudden decompression, and the uterus is going to say, "Okay, it's time for me to push this baby out," and then you're going to have problems. So you've got to have controlled release. So what the obstetricians have been doing, they've got a special device which opens the uterus, and it kind of seals. They put little clips on, which controls the hemorrhage. The liquor is then needled and or a tiny cut made so that it leaks out slowly. So it slowly comes down, and baby is then delivered. And you've got to decide whether you're delivering the head or head and shoulders. You usually head and shoulders and leave the rest inside to keep that uterus feel as if it's not doesn't need to expel the contents. So the head and shoulders are delivered, and then you start monitoring, because you can either, okay, this is now the iPhone 5 version where you can see it in 3D, but it's the same idea. At least it worked on mine. Okay, so here's you can see there's plenty of action going on in the room. There's all the monitors. But here they've opened the uterus, they've opened the abdomen. Now they're going to open the uterus, and they put a similar device on to open up the uterus so they can deliver. Right. So heads delivered, and attempts at intubation are made. In this case, it's Jonathan Perkins' hands, and I want to thank Jonathan for the slides that he's brought us. But this is how you monitor. Now you can either put an EKG on if you want to, or pulse oximeter. We've tried to get pulse oximeters, but it's a waste of time because the sats are going to be low anyway. It's going to be at about 65. But it does give you a pulse, but so does a sonogram. And so what has been happening is we put a sonogram on, and we can detect baby's heart. And if there's any situation where there's fetal bradycardia, then obviously you've got to go to the next step. We haven't got on to tracheoesophageal echo because it's all very well saying that's how you should monitor. But when you've got a cystic hygroma and trying to find the esophagus proved to be a challenge in our last case. So easier said than done. And you would do that if it was a cardiac issue, that you would deal, maybe a CDH or some other cardiac issue that the baby might have had. So it all depends on what you're dealing with. You can, if you're lucky, and this is also a video, but you can see this is the trachea. Believe me, this is the trachea, and this is the endotracheal tube. There's the two sides of the wall of the endotracheal tube, and you could see it go into into the trachea, and we're all very happy and said, okay, we've intubated, now we've got to see if the baby's going to breathe. So you separate from the placenta, clamp the cord, and move to the next room and hope for the best. This particular kitty did very well, and the tube didn't come out, but the second kitty, I was with Charlie Haberkern, and we were doing it together, and as we got across to the isolette, the nurses were, I think, taping in the tube, and then all of a sudden it came out. And so now we were back to square one with a baby who was desaturating. Charlie tried with a bronchoscope and was struggling like Jonathan Perkins had on the table, but at least Charlie had air coming in and out of the lungs. He struggled with the bronchoscope because it's an unfamiliar instrument, so I suggested to him to just look with a laryngoscope. So he did, and he said, oh, grade 1 view, thank you. So you've got to think about the things that you're familiar with, and you've got to deal with the issues that the most recent kitty that we had, by the time we left, by the time we clamped the cord and went across, we had 3 tubes in situ. We thought one was in the esophagus, one we thought was a false tract, or that we were dealing with something that was very abnormal because there were cystic lesions that we could see. But none of the 3 tubes were we very happy that the kid, that it was in the right place. So when I carried the kid across, which I think is the next slide. No, yes, they were carrying, it's not this one, but you carry it across the other room. And I started playing the flute on these different tubes in the hope that one of them was in the right place, because we had no idea. And when I attached the oxygen to the one that we thought was in the esophagus, the SATs, he started breathing, and the SATs all of a sudden picked up. And then we thought, right, this is the one. And we were having a look around and ready to fix it. And all of a sudden he went apneic, and I tried to bag through that tube and realized there's no way that it was in the right place. So then we had to go back to the basics, but at least on this occasion the air had been in the lungs, and I asked the nurse just to squeeze his chest, which she did, and I had a look and I could see bubbles. And that was the only view that we got of the larynx. The first attempt misfired, and the second attempt I got lucky, and it entered what was a normal larynx and a normal trachea, which we didn't think was normal when we were trying to do the exit procedure. So in most of ours, and most of them have been cystic hygromas, we've been in a situation where the baby has actually breathed for itself. Whether it could have been extubated straight away is very debatable. But I think the latest one may actually have been able to breathe on her own if we gave her a chance, but we didn't. Everybody was very twitchy and made sure that tube didn't come out. And it's still, I think it's now about 2 months old, and it still has not been removed, although we have looked at it and found that it's a lot easier, and it's virtually a grade 1 view nowadays. So that is, this is very odd, seeing your next slide coming up. I'm going to go straight on to the next slide. So that was the first one that we showed there. You can see he's got a patent airway, and he was intubated. That's what it looked like post-delivery. Okay, that's his MRI on his own ex utero. But this is a massive lesion, which in many situations is presented to us without going through the exit procedure, and they actually can be very tricky intubations on their own. But the secret is to look for normal anatomy and follow the normal, identify what you can see as normal, and then piece the things together, and hopefully you'll find where the trachea is. Bubbles help a lot, and I usually use topical lidocaine, which creates bubbles, and it also anesthetizes the airway, and it makes the child less likely to go into laryngospasm. So that's just a quick overview of, this is the kitty that we have in the unit at the moment. He's been debulked, and I believe he now has a trachea, and he's remained septic, and that's because we attempted to debulk this by putting in drains, and then subsequently got infected, and he's got some nasty bugs, and he's got a whole lot of other problems. But you can see there's no way that we could have done a trachea during the exit. So every case is an individual, every problem needs to be addressed and looked at and planned accordingly. And as Dan said earlier, coming together and meeting people for the first time and then having to coordinate needs a lot of communication, a lot of discussion. We're getting to know one another now, but it certainly takes a lot of effort and coordination to do an exit. And I haven't even spoken about the neonatologist role, who's the next step, obviously, once you've got the tube intubated. Are there any questions? No? Gee whiz. Enough already. No questions. Stunned silence.
I want to highlight something that Rosie said. So, that story where you said you've got a tube and you pass the baby off to another room, you lose the tube. Again, if you think about Agnes's first slide, all the things that go wrong in airway management, there's 8 things in there, 5 of which are in the human factors domain. This is communication. Okay? So, and it comes down to usually 2 people saying, "Oh, you've got the tube, yeah, I've got the tube. Oh, I thought you said sorry, the tube's out." Bang, can't. Okay? So it's usually as simple as that causes airway mishaps. And that's just the communication piece. And we've all seen it before. There's someone, I say something to you, you think you heard something else, and then there's an assumption made, and bang, you lost therapy or you lost